I just want to say first, thank you for the kind introduction. I mean, I don't have any words just to express how I really, truly an honor, not only to present here today, but I mean, I'm just speechless, seriously, like, because a lot of times, similar to Dr. Morris, I grew up in Puerto Rico, and a lot of the motivation for the work is embedded in those experiences growing up and seeing like how we can improve patient care for everyone, because it breaks my heart to see patients having incredible academic medical centers in Boston area and still receiving care like we were back in Puerto Rico when we didn't have that many resources, or a developing country where people don't have it. So, and those experiences are really what ground my work, and absolutely an honor to be here, present and listen to all the presentations in the day today. And I didn't know that you were going to use the the ACR change makers, but no, that definitely it been again. I many of the things that I do, and especially the work that um, I do it without expecting anything and recognition or anything. Because it's really what I'm passionate about. So, in the essence of time, thank you again for the opportunity to present today. We're going to share my screen. Can you see my screen? Okay.
Yep.
Perfect. Okay. Me. Let me just move this. Okay. Perfect. So today's presentation is going to be advancing health equity through health services research in radiology. I have to say that trailblazers like Dr. Morris are really what open up the door for people like me and others that were presenters today to talk about how do we improve access to radiology care, how do we improve operation and in care in general for our patients. So I'm very honored to be here with everyone today. These are my disclosures. So we're going to start to thinking about what happens with our patients. So when we think about where people live, you think that it shouldn't matter, or at least shouldn't influence how long you live or how well you live, but it does. So in this graph here, when we think about two different zip codes in the same state, and in a campaign by the American Public Health Association to talk about the differences in life expectancy, and you think about two different zip codes not that far apart, that it shows a decade more of productivity, a decade more of life experiences, a decade healthier. In the Boston area, we can think about differences in maternal-fetal medicine, what happens in the South Boston area and among our communities of color. And these effects have become more evident during our COVID pandemic. When we see our patients that have across the United States, where we have over 32 million new cases diagnosed up to at the beginning of May, and close to 600,000 deaths. I want us to focus on the states that have a darker blue color, because those are the ones that have a higher death rate. And if we compare those to the CDC percent of population living in poverty based on data from 2018, you can see that there's some similarity or a similar distribution in terms of like higher the states with the highest death rate and the states with the living in poverty. So it really what COVID has done for everyone is to magnify and really underscore the effect of social determinants of health and the environment in directly influencing health outcomes. Radiology has a front row view of the impact of the pandemic in our patients and into their daily lives. So if we think about not only all these patients have imaging findings that are consistent with COVID, but we think about individuals, I invite you to take a closer look at their social history when you're thinking about looking at their imaging cases, and think about their life beyond that imaging encounter. So we have patients living in overcrowded conditions, people that work at grocery stores or at a distribution center, which were considered essential workers, but or heroes, but they were putting their lives at risk and increasing their exposure, so we can we can have access to basic needs. And then people working 2-3 jobs at a minimum wage depending on public transportation, so really increasing their exposure. And then they come home living in an overcrowded room, and then you can understand why some of these patients were some communities were disproportionately being impacted by COVID. In a study that we did and published last year, when we look at racial and ethnic disparities in disease severity on admission chest radiograph among patients admitted with COVID-19, we use the modified radiographic assessment for lung edema, or MRAIL score, which typically is used for ARDS to analyze the radiographs of or score the radiograph of our patients presenting with confirmed COVID. And what we found in our study is that increased radiographic severity was associated with increased likelihood of worse outcomes and a composite score of intubation at ICU admission or death. And what we saw in our analysis that non-white patients had significantly higher disease severity on admission radiograph, and then increased severity among non-white patients was associated to delayed presentation and limited English proficiency, which correlate with the findings presented earlier about missed appointments or missed care opportunity in MRI. But we also wanted to better understand where our patients coming from and really try to use geospatial data visualization and analysis to understand where the community context for our patients, and understand this with using census data to take a deeper dive into our patients' circumstances on their daily lives. And when we mapped out where these patients were coming from, we can see that the majority, if we focus on the red, the zip code with the red color, which is the highest number of patients, these are tend to be in East Boston, Chelsea, Revere, Winthrop, Everett, and Lynn, among others. And when we think about census data and map this out, we know that these cities or towns have a higher population fraction of Hispanic Latino individuals by zip code, also have a higher percentage of individuals living in overcrowded conditions, defined as individual number of people per room, and also living in zip codes with lower median household income as well. So this just shows that not only the race, ethnicity, but also language, household income, limited English proficiency, and how this complex combination resulted in delayed presentation and more severe disease for COVID-19. But the disparities have not been limited to COVID. COVID just highlighted the existing health disparity gap among our patients. So when we look at in the study among Medicare beneficiaries and in the use of emergency department advanced imaging, so CT or MRI, when we think about emergency department, all patients, even those that have difficulty accessing care, will access care through the ED or urgent care because they'll take all comers. And in the study of almost 90,000 ED encounters to assess the advanced imaging utilization among Medicare beneficiaries, the authors found that Black patients were 32% less likely to receive advanced imaging. But not only that, both white and Black individuals in rural settings or rural EDs were less likely to receive advanced imaging compared to their urban counterparts. So this doesn't only highlight racial ethnic minority, but also think about rural communities, which are also vulnerable patient populations. But beyond that, Black patients were less likely to receive advanced imaging relative to white in all census regions. And why this is important? Because then when we think about racial and ethnic disparities in stroke care, imaging and radiology has a central role in the stroke care continuum. So if the people are having difficulties accessing imaging, then they will have access into their next step of care, which will be stroke care. So delays in diagnosis, worse outcomes. So if you think about already coming from a financially vulnerable situation, then everything continues spiraling down and impacting their lives and those of their loved ones. But more than just that, we want to think about each patient that is behind every imaging study and try to get their perspective and try to gain an understanding of how all these outside factors influence their care before we see them and when we see them. Because what happens is that all these factors like food and housing insecurity, low health literacy, limited English proficiency, lack of insurance, among other, what they do is fragment our care, and then that's where the disparity gap forms for our patients. And that's where, when we talk about falling through the cracks, that's where this happens. And we cannot talk about disparities without talking about social determinants of health, which are the defined as the condition in which people live, work, educate themselves, and access the healthcare system. including economic stability, healthcare access, education, and racism as well, that have become more of a conversation. Systemic discrimination, systemic racism have become more part of our conversation since COVID. And this also has taken a front and center, become a priority even at the highest level when we think about racism as a public health threat declared by the CDC, and then also talking about the confronting the impact of racism, more like in general, more like systemic discrimination is not easy work, but it's needed work, and we own it to our patients and we own it to each other, because this is what we need to do as a society. And the fact that this framework is an example of how the many forms of systemic discrimination, such as racism, transphobia, homophobia, among others, magnify the effects of all these social determinants of health, and will have a direct impact and worse outcomes for those that are most vulnerable and affected by many of this. And the figure published recently by in academic radiology, it talks about the social determinant of health influencing all aspects of radiology care. So we're not isolated from them. They influence how people come to imaging studies. They receive how they receive their imaging studies, how they understand the results, and how they also engage in their follow-up care. And we've seen today a wide variety of different studies trying to address different social determinants of health. From patient navigation through debunking some myths about medication, through also understanding what are some of the factors or community at risk for missed appointments, among others. And that takes us to research and outreach, informing radiology care delivery transformation. Because when we think about returning to care, the care that we were delivering before COVID was not working. That system is not working for many of our patients. So we have to rethink how we deliver care moving forward. And what we're trying to do in radiology race equity access and community health, or REACH care delivery transformation initiative, is not only we want to detect where are the gaps in care, but we want to take a deeper dive and understand our patients' needs. Look at them through our lens of empathy. And then we're going to use that information in partnering with our patients in developing programs to reduce health disparities. And when we also, it's important not only doing the intervention, but also measuring the effect, because we want to make sure that our approach is equitable, that our approach is benefiting those that need it the most. We know that blanket solutions only perpetuate disparities. So we want to make sure that we're tailoring access and tailoring access to those interventions to those that need it the most. So when we think where we start or how do we start, what I usually advise to trainees is just you can start anywhere, because patients that are in a vulnerable position will benefit from receiving any assistance now, because that's more than what they were receiving before. And as you embark in this journey, then you start understanding more and learning about other barriers to care. So during COVID, when we had this respiratory infectious clinic in Chelsea, we saw an opportunity for radiology to revamp our educational efforts to better prepare our patients. Not only we made it available in different languages, but also we use visuals, simpler language, so the health information is more accessible for them. But we also this opportunity for healthcare improvement and advancing health equity, drive innovation. We developed an app to reduce strain on medical interpreter services called RAD Translate. And what we saw with the whole purpose of this is just to liberate interpreter services to assist patients that had more difficulty navigating complex healthcare decisions, such as getting admitted to the hospital, maybe admitted to the intensive care unit, end of life care, and then use this app to provide patient breathing instructions when they were getting an X-ray. And that way we improve image quality, and then we allow a limited resource, which is interpreter service, to provide better care for our patients. And then in the end, also this application reduce the variability in each radiology encounter, which is important to avoid overcrowding of rooms or having many patients together, or delays in radiology care. And now this is being expanded to breast imaging, to pediatric care and other areas in terms of providing patients with procedural consent, among others. We also use data to inform interventions. And when we think about wait days, meaning from when the time the order is placed to the exam is performed, and we wanted to assess the effect of among different patient population, and we found that this effect of longer wait days and higher missed appointment rates or missed care opportunity rates was magnified among individuals who were from Hispanic or African American backgrounds, among individuals living in zip codes with a median household income of less than 50,000, and then among individuals with Medicaid. Even if we go close to 0 days that you basically can get the exam the next day, there's still going to be gaps for some of our patient populations. So it's not about only on detecting and trying to understand what are our patients' needs, but it's more just to use this information to develop the next phase or the intervention. How do we address it? And then that's what it takes us to programs such as the RIDESHARE program, where we offer transportation assistance to those patients that spontaneously express a need to cancel their MRI appointment because they didn't have a ride to the appointment or a ride home or a full round trip. And so we started this pilot in the Chelsea Outpatient Imaging Center. And when we found that this program benefited individuals who were unemployed, who have public insurance, and also older individuals, which speaks to populations that tend to be vulnerable, that depend on others or on public transportation to get to their appointments. Now I want to shift gears on an area that I've been focusing a little bit more, which is lung cancer screening and what the new future that we're building together looks like. Because lung cancer screening can serve as a model for person-centric systems-based solutions. We cannot think about a single specialty or a single individual to fix a systemic issue. We have to work together. So if we think about lung cancer in 2021, there's going to be an estimated almost 250,000 new cases, over 130,000 deaths related to lung cancer. And lung cancer disparities result from this combination of factors, from smoking duration, access to cessation, environmental factors and exposure, societal factors that we saw earlier, and then access to early detection, to screening. That's where lung cancer screening plays a role, because the best treatment for any cancer is to find it early. It gives patients the best chance of cure. But lung cancer screening utilization rates remain low across the board. In this study published from our team last year, we saw that utilization rate among eligible individuals range from 7% to almost 30%. But more importantly, in the study published from our team, looking at operational challenges in lung cancer screening during the COVID-19 peak and return to care, to speak to one of the study presenters earlier, it shows that although patients were, when we see the highest dip into lung cancer screening and any chest CT happening during the peak of the pandemic, on our return to care, sure, we're returning closer to what those pre-pandemic levels were, but we're still not there. And our patients, in particularly those that either have initial and follow-up lung cancer screening, are still catching up. And there's still a lot of hesitancy among different communities. And my concern, and this is something that was discussed earlier, is just that how the COVID pandemic has changed the demographic of those that are accessing care in a timely fashion. But more than just looking at the bare numbers, we want to also take a deeper dive into additional barriers to lung cancer screening. For example, in this study published by our team, when we look at it at readability level among lung cancer screening websites in the United States, where the American Medical Association recommended level is 6th grade, the median reading level for most of these websites was 10th grade and above. We see here the red line is the recommended 6th grade level, and basically all of them were above that level. When we also look at the analysis of out-of-pocket costs, so meaning if somebody is uninsured or maybe underinsured, although it's covered, many patients don't have insurance or are uncertain if the insurance will cover the cost of the study. And the average cost was approximately $583, plus minus 607, which is with an incredible range of from $49 to almost $2,500, and this is across ACR accredited facilities. So there's room for standardizing not only our costs, but also room for price transparency, which has become more prominent in our conversations in radiology. More than just that, more importantly, that is incorporating our patients' perspective. So this is a quote from our patients during a focus group asking, how do you go about asking a doctor to get a lung screen? And this patient was currently smoking and also was of age eligibility, met criteria, but she never had lung cancer screening. And that takes us to the next part, and we think about what do we do here and how we move forward, just because our patients' needs guide our care. We're going to think about person-centric team approach to system-based interventions, where the person or the individual is at the center of everything we do. We're going to, as radiologists, we're going to partner with our community stakeholders and then other specialties, because we're not alone in this. And Dr. Cruzco mentioned there are other specialties that want to get involved and that are involved, so why don't we work together? So when we think about the model that we published earlier this month, using the National Institute of Health, Minority Health and Health Disparities framework, and we adapted it to think about lung cancer screening intervention addressing different levels of a patient, provider, and systems, and also different areas for promoters of lung cancer screening awareness, promoters of opportunities, and promoter of participation. And then the end goal is to increase lung cancer screening, in this case among Latino individuals, but you can just swap that and just say it could be among African American individuals, it could be among rural communities. So how do we address this? Any intervention has to take into consideration the factors outside and inside and then the single individual level to be effective. So when we think about team-based approach to screening, in this case, collaboration between radiologists, chest radiologists, a PCP, the patient, and then radiologists in breast imaging, we integrated lung cancer screening surveys into screening mammography encounters, where we saw 89% response rate among 2,100 surveys. 11% currently smoked and 29% formerly smoked. And among those who currently smoked, a quarter of them requested referrals to smoking cessation. So it really shows that we can leverage a teachable moment in breast imaging where patients are engaged in their health, filling out breast health surveys to advance lung cancer screening and smoking cessation. So really an opportune window, because only 30% of eligible patients had lung cancer screening. When we think about the model team-based approach to screening, another collaboration between PCP, radiologists in breast imaging, the patient, and OBGYN, we offer a walk-in screening mammography program published by our colleagues in breast imaging, where people that were due or overdue for screening mammography and were visiting their OBGYN doctor or their PCP were given this card, and they could get their screening mammogram on the same day or schedule it at a time that is convenient for them. But it's important that we maximize each patient encounter for those that are most vulnerable, because overcoming multiple barriers to care is hard for our patients, and it's not feasible to expect that. But we also move that model of same-day breast cancer screening and apply it, right? So how do we scale things? By developing things that are sustainable and generalizable to other areas. So we think about research that is, we talk about divisions, or like in or subspecialties, we talk about division-less research, right? So how do we apply models into different areas? And we're thinking about using this model into same-day lung cancer screening for patients experiencing homelessness, and those in Chelsea Community Health Center in collaboration with our PCP and Boston Healthcare for the homeless program. So when we think about the road ahead, as we close out, what do we do moving forward? Really pursuing health equity, pursuing social justice in health. It's an important step, and radiology has established commitment to this through research, policy, advocacy, clinical care. Now we have established a radiology health equity coalition, because it takes all of us to achieve the goal of social justice. And our work is not done until no patient is left behind. So where do we start in radiology? We start with our patient, because and we start with each other, because we need to break the silos of between our specialties and within radiology. Let's move this goal of health equity together, because our approach needs to be deliberate and it needs to be different from what it's been.